Another week and another time to go inside EMS. I am your host, Chris Cebollero. With me always is my faithful companion, Kelly Grayson. KG, how are things going on in the Empire State?
Man, we're saving lives, stamping out disease and pestilence, the usual.
Yeah, but you've been stamping out all that stuff for decades.
There's a lot of disease and pestilence, man.
Is
It's
that
just
right? Okay.
the work never ends.
Kelly, one of the things that we always talk about is we try to come with some good topic, and clinical topics are really, really hard sometimes. You have a tendency to talk a little bit deep. Sometimes we need to be able to make things a little bit easier, but we need to be able to get to a point of bringing some clinical topics every now and
Yep.
again. And I think we've fallen off that path. So we're gonna join that path again today, and
Yeah.
we really want to be able to talk about DKA in the show. But let me give you an opening scenario, Kelly. So
Okay.
you respond to a call, 19-year-old, she's found confused and vomiting. The patient reports, or the parents report, I'm sorry, that there's a history of type 1 diabetes. Vitals show tachycardia, rapid respirations, and blood sugar of 500. What are you going to do? But why this matters is DKA is a time-sensitive condition, an emergency condition that we need to be able to address and address quickly. And oh, pardon me, the relevance is that we're starting to see more increasing calls for type 1 diabetes, insulin-dependent type 2 diabetes, and we
Yeah.
need to be able to understand what we're doing. I guess you can't drink ginger ale before you start because it's just been up and up here, but I'm going to stop talking and let it go to you. So, Kelly Grayson, if we were going to talk about DKA, give us the definition of what DKA is.
DKA is diabetic ketoacidosis, and it occurs when the body, oddly enough, the glucose level is high, but that's the blood glucose level. The cells themselves, because there is not insulin produced in sufficient quantity to open those gated channels into the cells, the sugar stays out there in the bloodstream and doesn't reach the tissues. And those tissues, which normally need oxygen and glucose to survive, have to turn to an alternate energy source, and they start burning fat. They start burning that spare tire around your middle. And the metabolism of fat produces less ATP, and it produces a whole lot of harmful byproducts, particularly ketoaldehydes, which is what you smell in diabetic ketoacidosis.
Yeah. And so if you think about it, what's determines, I mean, if you think about a blood glucose or you think about a pH, what are you expecting to see there?
Well, the patient with diabetic ketoacidosis, I think the level, the glucose level at which it starts to occur is probably going to vary with patients, but it's typically patients with glucose well over 300. Your body will, when you have this acidosis, this ketoacidosis, your peripheral chemoreceptors, your central chemoreceptors are going to start saying, "Oh my goodness, the pH is too low. We need to breathe faster to blow off some of this pH." And for every 0.08 the pH moves, CO2 moves 10 in the opposite direction. So if you breathe faster and blow off, you'll blow down 10 millimeters of mercury of CO2, the pH will rise 0.08. So naturally, the patient who is in diabetic ketoacidosis will necessarily breathe faster and deeper than normal because they're trying to attenuate that metabolic acidosis with some respiratory compensation. A lot of people go
what? Attenuate?
that attenuate that
Attenuate.
attenuate, compensate, whatever you
Yeah,
desire.
I'm just checking it out, man. You're using
Pick your verbiage, man. Pick your
you're using
verbiage.
a 50 cents word, 50-cent, $5 word there. But all right, so let's talk about I think you gave us a good understanding. But when we talk about the pathophysiology here, we know basically cells can't get enough glucose. Can you take us through that pathophysiology?
Are you going to make me talk about the Krebs cycle? Oh my God.
No, I don't think I want you to talk about the Krebs cycle, but if I was going to hit you with this, I would say that cells can't get the use of glucose.
Yeah.
It breaks down fat, as you said. Then
Yeah.
fat metabolism produces ketones, which are then acidotic.
Yeah.
Leads to metabolic acidosis.
Yeah.
Acidosis worsens, compensatory mechanism.
Yeah.
So you just kind of jumped around. I wanted you to make it more linear.
Okay.
Since I just did it, I am going to leave you to your senses.
All right. Okay. Were you a sergeant in the military? Because that's an excellent knife hand you got there,
Oh, you
man.
like that? You like
It's the knife hand.
right in the thing, man. But
Um, It's far from a linear progression, but it's simplified. It's can't get enough glucose. Your body needs an alternate energy source. It's going to start burning fat, and that fat is going to produce ketoaldehydes, which cause acidosis, and your body is going to breathe faster to compensate for that acidosis.
How hard was that? How hard was that?
And also during that process, you're also going to diurese quite a bit because the excess glucose is going to spill over into your urine, and it's going to take sugar, it's going to take fluid with it. So that oncotic pressure of large molecules of glucose, and lots of them, is going to pull more water into the collecting tubules, and you will pee more, to the point that there's a reason people have dry skin and they're not pale and sweaty in diabetic ketoacidosis, because they're freaking dehydrated, to the point that we as ALS providers probably need to start an IV on them and give them fluids to replace some of that fluid loss through diuresis.
That's a big miss a lot of times when paramedics are dealing with DKA. I'm glad you brought that up. So if we were going to talk about a patient history, we get on scene and maybe we have witnesses there, we have family member there. Take us through what a patient history would look like.
Well, the vast majority of the time you see diabetic ketoacidosis, it is a type 1 diabetic. Occasionally type 2 diabetics get it, but the vast majority of the time you see DKA. It is in a type 1 diabetic. In fact, that's the presenting symptom of the vast majority of new diabetics diagnosed. They have DKA. Mortality rate prior to 1921 was 100%. It was uniformly a fatal disease. And I forget who discovered it, but they discovered insulin. They could synthesize it. And now the mortality rate nationwide is less than 1%.
That's why the best color man in the business right there, because that.
These patients will primarily, the easy take home is they will have the 3 Ps: polydipsia, polyphagia, and polyuria. Polyphagia, not so much that you would see in DKA. Polyphagia is hunger, but polydipsia is an increased thirst mechanism, and polyuria, they will be peeing like a racehorse. So they get dehydrated this way. And keep in mind that we lose most of our body water every day, not through urination and sweat. We lose it through vapor loss when we breathe out. So when you start breathing 28, 30, 32 times a minute, 36 times a minute for a prolonged period of time, you're losing a lot of fluid just through your hyperventilation.
And that's one of the things, just stop right there though. One of the things that people don't know, especially if you're a critical care paramedic, is that when you intubate somebody, that water vapor is kind of lost, and you've got to take that into account. But that's a whole other show. But so when we think about signs and symptoms, you kind of talked about it. I don't know, you hit neurologic, where we talk about confusion, where we talk about drowsiness, headache, decreased level of consciousness. I think we've all been on those calls where people are like, just kind of out of it. You talked about respiratory, Kussmaul respirations. Go ahead and give the kids an example of what Kussmaul respirations is. Let me see your acting face.
Kussmaul.
No, I want you to do the there you go. Okay, good. So that's usually Kussmaul respiration.
Make me hyperventilate myself into
an old Kelly Grayson walking up a set of stairs. Okay.
No, that was me walking up a set of stairs 2 years ago.
Oh, now, so that's what I meant. The old Kelly Grayson. Right?
You're not gonna see me do that now. Technically, Kussmaul respirations is tachypnea and hyperpnea. Tachypnea is rapid breathing. Hyperpnea is abnormally deep breathing, and it's a compensatory mechanism that as an EMS provider, you should not freak out when you see this. This is what we call effortless tachypnea. A patient who's breathing that fast, people who were taught the monkey see, monkey do version of EMS, if they're breathing faster than 28, you must ventilate them with a BBM. That's not the way it works.
Right.
If they're breathing effectively, there is a reason for them to be breathing that fast, and you don't need to mess with that mechanism. Paramedics.
It's time for you to start investigating more when you see that.
Yeah, time for you to start investigating. And one of the worst things you do if that patient craps out is ventilate them at a normal respiratory rate. Their respirations were 32 or 36 for a reason. And if you don't take that into account when you ventilate them, you're not helping them compensate for that acidosis. But one of the big clues in the scenario is the vomiting. The vomiting. Lots and lots of DKA patients will have vomiting and abdominal pain. And
let's touch on the abdominal pain, because a lot of times they'll present with abdominal pain, but are you really thinking that it's a metabolic issue? Or are you trying to figure out what's going on with the abdomen?
Yeah.
So you have
a lot of rule outs. Yeah. When they complain of abdominal pain, you have to go through your differential diagnoses of all these things that can cause abdominal pain. And if those things are not present, well, probably the reason for their abdominal pain is the electrolyte imbalances and the cramping that happens in muscles when you get hyper or hypokalemic.
But one of the things that we have to be able to think about is not get the tunnel vision, and we need to be able to think metabolic. Same thing with people who we think are crazy, right? They're out there screaming in the street, and we're gonna, take them to a psych ward. Do you ever consider the metabolic aspect of what's going on here? And I think sometimes we just jump to conclusions. But Kelly, let's talk about diagnostics now. Vital signs. So when we think about vital signs, what are we going to see?
They're typically going to be tachycardic because they are dehydrated. They will not have that sympathetic nervous system response that you see with hypoglycemia. They won't be pale, they won't be sweaty, they may even be flushed. They'll be tachycardic, and they will have this effortless tachypnea. They're breathing very fast and very rapid. But if you listen to their lung sounds, they'll be clear, and they'll probably have an oxygen saturation of 100%. But there is one thing you can check that is almost 100% diagnostic for DKA, and it is now an EMT level skill. Capnography, waveform capnography. If you have, and the numbers are a little different for adults than they are for pediatrics. I think it's for a pediatric, if you have a CO2 consistently less than 29 and a high blood sugar, that pediatric patient is in DKA. If you have an adult who's hyperglycemic and has a CO2 less than 24, that patient is in DKA. It's almost 100% effective, sensitive and specific for ruling in or ruling out DKA. And that's something that a lot of EMS providers may not know. Capnograph can clue you into a whole lot of metabolic derangements.
Yeah, that's a good one. What did you say the pediatric was?
I think it's less than 29 for pediatrics and 21 to 24.5.
Yeah, I always went less than 25, but
yeah.
You may be right. We need to get Pete on, and maybe he can clear that up for us. But all right, so EKG, what are we looking at?
Depends on, usually it'll be a sinus tachycardia, but if the patients have some pretty significant electrolyte derangements, you're going to see signs and symptoms of hyper or hypokalemia. I remember one time I had a 26-year-old kid that was pretty obviously in DKA. We found out later at the hospital, his pH was 6.9. and his glucose was 1132. I've never heard of a DKA patient having a glucose that fast, and his potassium was over 10. I think it was almost 11. Those numbers are incompatible with life.
Yeah.
And I saw this.
Did the kid pass?
He lived. But when I saw this and I did a 12-lead EKG on him, it goes boom, he's having a STEMI. And protocols required that I notify the hospital if the machine said STEMI, although I knew certain that machine was wrong because it didn't take into account everything else. So I get him to the hospital. Of course, they do the cath lab activation, and they're about to ship this kid to the cath lab. And I'm just shaking my head to myself. And my partner said, "What do you think's wrong with that kid?" And I said, "Well, it's not a dang MI. It's hyperkalemia, almost certainly." And the doctor happened to overhear this, and he said, he kind of chastised me for differing with the 12 lead. And I said, well, these things make mistakes just like human beings do. It's a machine. It's not infallible.
Just always trouble with people.
And he goes, well, why do you think the machine's wrong? And I said, well, first of all, the machine says that sinus rhythm, and it's clearly third degree AV block. And he pulled the EKG and he looked at it again. He was like, you are right. And I was like, so if I can get the rhythm analysis wrong, what do you think it's going on? So as I was pulling out he hopped up on the running board of the ambulance. I was pulling away, knocked on the window, scared the heck out of me. And he says, glucose 1132, pH 6.84, potassium 10.5, dapped me up. And I was like, thank you, sir.
That's funny. I mean, that's good.
But that sort of thing, if you don't know what you're looking at and you rely on that one piece of information, you can make a mistake.
Right. So when you think about EKG, peak T waves, prolonged PR interval, widened QRS, now in late signs, hypokalemia from insulin fluid shifts, you think about flattened or inverted T waves, U waves, ventricular ectopy, and eventually cardiac arrest. So management of DKA, KG, what are you taking the list through? I'm
gonna clarify one thing on the EKG stuff. They all teach us that that a EKG with tall peak T waves is indicative of hyperkalemia, and it is. but it's indicative of, oh, that's interesting, hyperkalemia, not it's going to kill him hyperkalemia. When you see life-threatening hyperkalemia, it does not look like an EKG anymore. It more likely resembles the pleth wave on your pulse ox. When it turns into a sine wave, that is the really severe hyperkalemia that's life-threatening. Management-wise, it would be nice if we give these people 10 units of insulin, but most EMS systems do not carry insulin on the ambulance. But the one thing you can do is assist with their respiratory compensation. Certainly don't interfere with it. If they've got a good oxygen saturation, leave it alone, but give them fluid. Give them fluid. They say that you need to start an IV and run 150 milliliters an hour of saline just to keep up with the fluid loss. They're probably going to need more fluid, significantly more than that. Hyperkalemia, if you think that it is life-threatening hyperkalemia, they say the bicarb's old school and it's not that effective and it's temporary only. If you really want to worry about treat hyperkalemia aggressively, calcium chloride or calcium gluconate. If you happen to give bicarb as well, make sure that you flush that IV line thoroughly between the two. But one thing that is very useful is continuous albuterol nebulizers. Albuterol causes a pretty significant intracellular shift of potassium, and its effects start in about 5 minutes, and they last till 5-10 minutes after you stop the neb treatment. So that's a quick, dirty, and easy, effective way to treat severe hyperkalemia. And there's also activating the insulin pump as well. A lot of people with these hyperkalemic, severe hyperkalemia will get 10 units of regular insulin and an amp of D50 because every molecule of glucose you move into a cell takes 4 molecules of potassium with it.
I think that one of the things that you want to be able to think about is, for type 1 diabetics, type 2 diabetics, if they're older and you're starting to give fluid, make sure they're not renal patients, make sure they're not CHF patients.
Yeah.
Because if they are, you really need to worry about the risk of fluid overload, right?
Yeah.
So, all right, Kelly, let's go ahead and make a shift a little bit. When we think about this from a special populations and pediatric and elderly, I kind of gave you one. What about pediatrics? What do you think is the thing we should consider in the pediatric patients who are diabetic?
The nice thing about the pediatric patients is they probably don't have those renal issues and they're probably not CHFers. So, and they also turn around radically well with fluid boluses. These kids who, and a lot of these, the juvenile onset diabetes, this is the first way that they find out they're diabetic. And these kids may actually be fairly used to it and have a glucose that you think is just crazy high, and they're going to school with it. Nancy is the resident expert and my subject matter expert on that because her daughter was a juvenile onset diabetic, and she was complaining of stomach aches and headaches and fatigue. Had been for a while until someone finally, they took her to Yale, which is one of the worldwide foremost research centers on diabetes, and discovered her blood sugar was like 600 and something, and she'd been walking around like that. And as it turned out, it took so long to figure it out because she was having her younger sister submit the urine samples. So, yeah. So they finally got a good urine sample. Yeah.
So
but
I do want to give you a perspective, though, Kelly.
Yeah.
In the world of community paramedicine, we may be taking care of patients that are type 1, type 2 diabetics. They may be very brittle. We may need to teach them how to use a sliding scale and a lot of things. But one of the things that I want you to be able to think about as well when we think about the social determinants of health is, why are they missing their insulin? Can they not afford the insulin? Are they not able to get the insulin?
Yep.
Are they depressed? Do they have a financial hardship where they can't pay for their supplies? Do they not have insurance? They have poor access to care. They lack diabetic education or support. So now, as you start to go through your process as a community paramedic, you've got to be able now to make the determination of, why are they non-compliant with their medications? Is it because they just don't want to, or is it because they can't afford, or something else is going on? So now the social determinants of health come in, and you've got to now think about the next level in how you can help them with the resources they need to live a better quality of life. So let me give you a quick summary before Kelly Grayson uses his $50 words again. But Kelly, I'm going to come back to you and ask your final thoughts on dealing with a DKA patient. DKA is a metabolic emergency. Early EMS recognition will save lives. A lot of times we may be running on these people pretty regularly, as Kelly mentioned, new diabetics. And we talk about new diabetics. A lot of kids are getting type 1 diabetes and they may not know how to take care of it. Remember, the parents are taking care of them. But then also we have to worry about the type 2 diabetics, right? Because they don't know how to, they've been living their life for 40 years, 50 years, and they don't know how to deal with it. Key signs, Kussmaul breathing, fruity breath, altered mental status, dehydration. You want to give fluid resuscitation is often only the pre-hospital thing we can do unless we have insulin that we could utilize, or if they have insulin and you have it in your protocols to give them. Monitor the EKG closely, get them to the hospital as quick as practical. But Kelly, Grayson, give us your final thoughts on dealing with a DKA patient.
Yeah. These people don't mess with their respiratory compensation, give them fluids. Pretty much any hospital, even the small ones, can start IVs and start correcting electrolyte derangements and give people fluid. A lot of times these hyperkalemic patients and these acidotic patients are going to be handled just fine by correcting their fluid deficits and correcting their glucose. You correct their glucose with an insulin drip, just getting their glucose back down to normal level is going to manage the lion's share of the hyperkalemia. One thing I wanted to mention before we sign off is in type 2 diabetics, the non-insulin dependent type 2 diabetics, they are prone to another syndrome that is not DKA, it is HHS, hyperosmolar hyperglycemic syndrome. These patients, these type 2 diabetics, still produce insulin in some degree. They may produce normal amounts of insulin, but the receptors that allow insulin to make it shepherd glucose into the cell are non-functional. HHS is far less common than DKA, but is far more lethal. I forget the mortality rates, but it's like 30+%, and it is a killer. The clue there is these patients have crazy high blood sugars, but they don't have Kussmaul respirations because they're not acidotic. It's hyperosmolar, hyperglycemic, non-ketotic state. So these patients need fluid in the worst degree.
Glad you remembered that. That was an important point we forgot.
Yeah, so we see a lot of diabetic patients, folks, and there's more to treating a diabetic emergency than just, oh, their blood sugar is low, let's give them some glucose. We can do a lot for the hyperglycemic ones as well. Keep that in mind that as an EMT, if you have a patient with a high blood sugar and they're doing Kussmaul respirations, their CO2 level is less than 24 or 25, that's a call for a paramedic intercept, and you need to get a paramedic there and start some IV fluids on them. But if you do those things, you will reduce mortality and you will improve patient outcomes by aggressive assessment and treatment of diabetes. That's it. But you've heard what we think on the issue. Are there some tips and tricks to diabetic emergencies that we haven't covered here? And what are they? We'd love to share them on a show. So email us at theshow@ems1.com. And for myself and co-host Chris Cebollero, thanks for turning in to Inside EMS. We're going to catch you next week.